I don't know how you make time for it.
You know what? If there's a will, there's a way. I gotta say, being a neurosurgeon is easier than being a dad.
World of Pain MD podcast is for information, education, and entertainment purposes only. This applies to all information, graphics, videos, and content on the affiliated website and podcasts. The aforementioned does not constitute medical advice, nor does it establish any patient-physician relationship. The information and content on this website do not substitute for any professional medical diagnoses, treatment, or advice. Seek advice from a qualified healthcare practitioner for any questions you have concerning a medical issue, including treatment. Do not delay consultation with a professional or disregard their advice based on the information on this website or podcast. The opinions, statements, and views are that of my own and do not reflect those of my affiliated institutions, policy, or any entity.
Hello and welcome to World of Pain MD podcast, where we discuss all things pain with the experts. I'm Dr. Derek Davis, a PM&R resident who's subspecializing in pain medicine. In this episode, we speak with Dr. Alan Chalil. Dr. Chalil just finished his fellowship in functional neurosurgery, which is a subspecialty of neurosurgery that he will describe later on in this episode. We speak primarily on what pain is and what functional neurosurgery can do to help alleviate and treat it. Dr. Alan Chalil immigrated to Canada at 16 years old. He went to the University of Waterloo for undergraduate and graduate school. He attended medical school at the University of Toronto, did his neurosurgery residency at Western University in London, Ontario, then completed his fellowship in functional neurosurgery at Emory in Atlanta, Georgia. He oozes with the cool, calm collectedness you would expect to see of a neurosurgeon on TV. In fact, I'm not 100% convinced that he's not just Oscar Isaac posing as a functional neurosurgeon. I hope you enjoy this episode and learn something, and thank you so much for watching.
So you are a functional neurosurgeon. Could you explain what functional neurosurgery is, how you would explain it to patients, and how you would explain it to colleagues like in the medical field?
Mm-hmm. So, functional neurosurgery is a branch of neurological surgery. So, if we define neurosurgery in general as surgery of the brain and the spine and the spinal cord, as well as the peripheral nerves. Functional neurosurgery is the branch that focuses on restoring function to anybody that has any sort of disability from neurological diseases. So that could apply anywhere from movement disorders, so patients that have tremor and Parkinson's disease, where they would have a lot of difficulty moving and controlling their fine movements. So we can do surgeries to help them with that, as well as epilepsy, where patients may have disability because of seizures, and they kind of lose quality of life, and possibly could also lose their life secondary to seizures. So we help with that. And then the third branch of that would be pain, which kind of branches out to psychiatric conditions as well. So pain, including chronic pain, visceral pain, cancer pain, all that, anything that that stops patients from enjoying their quality of life. That's what we try to deal with in functional neurosurgery. Some centers also include peripheral nerve, which is Emory as well. So peripheral nerve surgery falls under functional neurosurgery in this center, and a lot of other centers do that too.
You did a pretty good job of explaining sort of what patients you'd be seeing in clinic and in the OR, but when should a patient come see you? Because some of these disorders are managed, by a not a surgeon, first of all, and then there's that sort of in between with a proceduralist. But when do you think your colleagues or when a patient should come see you directly?
Mm-hmm. So that's a good question, because a lot of these conditions, if not all of them, are managed medically, which means that patients take medications or in the events of psychiatric conditions, they also do psychotherapy as well. But a lot of the times, whenever you're dealing with neurological conditions, the medications that you're taking have significant side effects. And no medication in general, as you know, we take that's completely side effect free. But specifically when you're dealing with neurological conditions, whether it's Parkinson's disease, whether it's essential tremor, or epilepsy or pain, you always have these bad side effects associated with medications. And that becomes a balance between how much medication can you take to improve your quality of life, but then your quality of life will start going down because of the medication dose that you're taking. So patients usually come to see us whenever they do not respond to medications. So they've tried conservative non-surgical management. So they try pain medications or Parkinson's disease medications. They continue to have symptoms, and then they get referred to us. So we can basically consider if any surgical intervention can help. But also they see us whenever they're taking medications, they respond well, but they cannot take as much medications anymore because they could be sedated or could be having side effects, whether it's liver failure or hematological side effects, like it's affecting their blood levels. And that's when their doctors would seek the help of a neurosurgeon to see if they can help with surgery for these patients.
Do you see a particular time course for a lot of patients? And I know most patients vary so widely, so it's hard to say, but is it after about like 6 months that, like, oh, we're not getting better, we're not getting improvement with these oral medications, or they're needing to take more, but they can't tolerate it? Is there a time frame that you typically see patients in, or not really?
It varies. It depends on what we're talking about. So and also depends on where you're practicing. So, as you mentioned, I'm from Canada, and I have to say, in Canada, we're not as aggressive with referring patients with Parkinson's disease and movement disorders to surgeons, and that comes because of the way the healthcare is funded in Canada, possibly. Is that we try to maximize medical management before we go for expensive and risky surgery. But in the United States, I noticed in the last year that we are much more aggressive in treating patients early on with Parkinson's disease. And not only, so a lot of people with Parkinson's disease, they would see us anywhere between 2 to 5 years or even 10 years after we get diagnosed. But here we're much more open to kind of having them early on. In terms of epilepsy, now, epilepsy has a general trend of being under referred to surgeons. There's a kind of a, I don't want to call it old school thought process or school of thought that says that epilepsy is not a surgical disease. A lot of epilepsy is not a surgical disease. About 60% of that is not a surgical disease, but the rest of it is, and those don't get referred to us for another 2-3 years after, or even longer, even 10-15 years after they develop epilepsy. Pain is a different animal altogether. With pain patients, usually, if you want to follow the definition of chronic pain, is pain that's been experienced from 3 to 6 months or longer. So we don't tend to see patients that have acute injuries. Usually see patients about 5 years, I would say, on average, after the onset of their pain. And that's when they have tried everything and they come in to you as a last resort for that.
And this is a question more pertaining to you, but I know you have your master's in physiology and nutrition. I was wondering, do you incorporate that in some ways or another into your practice as a neurosurgeon?
I wouldn't say it. Yeah, no, I don't think I incorporate my knowledge from that aspect into practice on a daily basis. It's more of a research interest. I kind of, having jumped institutions throughout my training, I kind of followed opportunities. And during my undergraduate studies, I enjoyed two of my courses in health sciences, and both of them were the same professor, Professor Ken Stark. And I enjoyed his view on metabolism, and he was into working out, and I was also trying to get fit and getting into working out. So I joined his lab out of interest, and that kind of grew to become a master's degree after undergrad. But I've always kind of saw opportunities, saw interest, and then that's how led me there. On a daily basis, I wouldn't say that it affects my view. It's kind of a separate side of the same coin, if you want to say. But no, it doesn't really relate much to what I do on a daily basis.
Absolutely. Yeah. When I first met you, I was like, how is this guy in such good shape for being a neurosurgeon? I don't know how you make time for it.
You know what? If there's a will, there's a way. I gotta say, being a neurosurgeon is easier than being a dad. After being a dad, after becoming a dad, that was difficult because you're tired all the time, especially in the first couple of months. But I try to the only way I do is honestly going in the morning, where I just go and first thing when I wake up around 4 o'clock in the morning, just go get your hour in, and then you wake up and then you start your day then. But yeah, as you know, we were in the OR together recently, and you see how like cases kind of come out of nowhere, right? They pile up, and you don't know what time you're gonna go home. So yeah, the only time is when you wake up. That's the only time you can do it.
Gosh, how many cups of coffee deep are you when you get to the gym at 4 a.m?
So I usually start with a Red Bull.
Okay.
I don't know if you could, if we could advertise for Red Bull on here, but
Yeah.
yeah, I start with a Red Bull in the morning, and I start with an espresso, double espresso in the morning. Usually the crash hits you around 2 o'clock, but I've been pretty good. I keep it at usually 1 or 2 coffees a day.
Nice. Okay. So
Yeah.
what procedures, operations, surgeries can a functional neurosurgeon offer someone with acute or chronic pain?
All right. Yeah. Well, where do we start? Okay. So to answer that, we have to take a step back and then decide, when are we treating pain? So as you know, pain is not a single entity. Pain in general, the way your brain perceives pain, is just to tell you there is something wrong with your body. That's it. That's the intention of it. So there has to be damage somewhere. That's normal pain. So if somebody breaks their leg, then their pain that they feel is trying to tell the brain, your leg is in danger. You need to figure it out, kind of treat it. Now, that is known as visceral pain. That part of pain is normal. Everybody experiences that. When it becomes abnormal is when you start experiencing pain when there's no tissue damage. And that is because there's a problem with either your nerves, the wires that are attached to our limbs, or in the spinal cord, so a spinal cord injury or a nerve root avulsion, brachial plexus avulsion, something like that, or something different in the brain itself that's basically causing me to think that there is pain. Now, these are treated differently. These types of pain and the location of the damage, all of them are treated differently. So if we want to focus on neuropathic pain, because it's a little easier to treat than visceral pain, when we start with the peripheral nerves, what we can do is we can either decompress whatever damage is being imposed on this nerve. So if you have a disc that's herniated and that's pressing on the nerve root, we can take out that compression, and then we can heal that pain. If you have an ulnar neuropathy, so people come in complaining of pain along these fingers, coming from the elbow, we do a decompression here, carpal tunnel, they can cause tingling and pain in the fingers, similar situation. Sometimes the nerves are too damaged for them to heal on their own. And when we're doing these surgeries, we can put a stimulator on the nerve or on the brachial plexus. And I don't know if were you with me in the OR when we did that? Yeah. So we did a brachial plexus decompression, and then we added electrodes, which are wires essentially that deliver pulses of electricity to jam the pain signal that's coming from these sick nerves. And going more closer to the spinal cord and the brain, sometimes you have pain that's originating from the spinal cord or from a diffuse area in the body that you can't cover it with small surgery. So you go to the center, which is the spinal cord, and you can put these wires on the spinal cord to jam the pain signal there. So that comes in handy whenever you're dealing with something like failed back surgery syndrome or persistent spinal pain syndrome, as it's commonly referred to now. So those are patients that have back problems, fusions, that persistently have back pain and leg pain, and such a big area to cover. So you go and you put these stimulators on the spinal cord and try to jam the pain signals there. Then I think I referred to it earlier, which is brachial plexus injuries. Those are difficult, and they kind of are the cousins of phantom limb pain, which is a very commonly known type of pain. Um, so it's whenever somebody has, usually it's motorcycle accidents. So somebody has a motorcycle accident, they lose a limb, or maybe they still have the limb, but they have severed all the brachial plexus from the spinal cord. And that type of pain produces this, it's called deafferentation pain, where the pain is originating in the spinal cord where the cells are attached to the nerves that kind of innervate that limb. So when you have an injury that severs that limb, these cells are kind of left empty and they don't have anyone to talk to. And they start firing at a rate that tells the brain there is pain when there isn't. And for that, we do more invasive surgery. So we go into the spinal cord and we can cut into it. We can even go further into the brain and do the same thing where we can burn areas in the brain that are responsible for pain, and or put a electrode or a wire in the brain, like deep brain stimulation, to modulate pain that way. So really the options are endless in a way. You can do any of these or a combination of them, and it really should be tailored to each patient and the pathology they have and the type of pain that they have.
That deafferentation pain, that is going to be a central nervous system process. Is that right?
Correct.
Compared to perhaps a phantom limb pain, which is more a peripheral nerve phenomenon.
So to a certain extent, yes. So phantom limb pain is when you have a injury to a limb, and you have an amputation of the limb, and your brain is not aware that that limb is gone, and it still produces sensation related to that limb. Now, we talked about pain earlier as, it's a sensation that tells you that there's something wrong. But really, if you decipher pain itself, pain is any uncomfortable sensation. So, and then think about if somebody scratches your car. The car has a physical injury, but depending on what kind of car you have, you might feel the pain yourself because there's an emotional aspect to that. So whenever you have a phantom limb sensation or pain, that pain could be anywhere from real pain and discomfort to itching, to feeling that your limb is the size of a room, or your limb is stuck in a weird position. So can you imagine that you feel like your arm is stuck over your head for hours and hours and you can't move it because your arm doesn't even exist? So that is an uncomfortable sensation. So that is what phantom limb, the umbrella of phantom limb, describes. The afferentation pain is what we described earlier in terms of the injury to brachial plexus, or it could happen in the thalamus, which is a relay nucleus in the brain with strobes and all that. So you end up with loss. It's a parallel process that happens with kind of similar to phantom pain, but happens in the central nervous system, where you lose input from these cells and you start generating these sensations that are usually pain when there is no reason for you to be feeling that. And that is a much more difficult kind of pain to deal with than any parallel processes or other processes that we see.
So you mentioned earlier about going into the spinal cord itself, I believe, and then also potentially the brain and different areas within the brain. Are those, in some aspects, sort of that dorsal root entry zone procedure that we're talking about, the DRES as it's known, or I suppose, I guess a little bit further out would be like a rhizotomy? So what would be some indications for either one of those procedures?
Mm-hmm. So, yes, that's precisely what I was talking about. So there's, in the spinal cord, we can do these procedures, rhizotomy, DRES, dorsal root entry zone ablation. We can also do a chordotomy or a myelotomy. So these are all fancy words for basically trying to either destroy or cut out, so destroy the cells that are generating pain, or alternatively cut out the connection that's producing pain or that's carrying that pain signal to the brain. So in Dre's situation, we're thinking about usually a brachial plexus avulsion injury. So to understand that, we have to take a step back and understand the anatomy of pain, where you have the pain fibers, the sensory fibers in your hand, say. These carry the signal to a cell body in an area called the DRG, dorsal root ganglion. That cell branches out, puts another arm and a process into a cell in the spinal cord, which is the second order neuron. When you avulse that proximal arm, so one arm is still connected to your hand, the cell body is still intact, but the other arm is disconnected from the second neuron, then that second neuron it loses signal, and it starts interpreting any signal it starts firing even uncontrollably, almost like an epilepsy short circuit. And it starts firing and sending signals to the brain, telling the brain, I'm in pain, you have a problem. And usually it's your arm, because that's the sensation that you lost. In that situation, the easiest way to control the pain would be to go in and burn that neuron, that DRES. That's done with an open procedure. We go in, we find where these nerve roots are avulsed, and then we go in about a 2 millimeter depth in the spinal cord to burn these cells and cut off the pain signal. And the rare surgeries, I have done about 6 of them in my training. They are probably the most satisfying surgeries we do, because patients usually are suffering from pain for 30 years or so. And then for the first time in years, they wake up with no pain. And that's such a satisfying feeling for them. Yeah. Yeah, it's hard. The thing is, it's a scary surgery, because I mean, you're trying to convince a patient that, I know you're in a lot of pain, but you're going to take all that risk that I'm imposing on you, and we're going to cut into your spinal cord. And that sounds absolutely crazy, but that it does help a lot. Now, the other patients that may have some sort of cancer pain, or they may have midline pain that's in their body, not necessarily neuropathic pain, or they might have rib pain or post-herpetic pain if they have shingles. So these patients can be treated with a rhizotomy, also a very rare procedure. We do them usually for either for chest wall pain, so something like somebody has had a rib injury and they had chronic pain from that, or they could have post-herpetic neuralgia from shingles. We don't do it often because we have good neuromodulation options to deal with that, which would be something called dorsal root ganglion simulators, which are basically wires that go and control the pain very nicely without the need to open the spinal cord to do this. The other alternative is that some people have facet pain, and that's part of back pain. And the facets are the joints in your back. And actually, I have a spine model here. So these facets here, so they're the joints, and you can see when you move, these joints move. And sometimes the degenerative process, the arthritis that happens in the spine, could cause some pain in the joints. The same thing happens with pain in our hands with arthritis. And for that, we can do a rhizotomy where we burn the nerves that are going to these facets. It doesn't change the degenerative process in there. It just stops the feeling coming from that. So that's a rhizotomy. Cordotomy and myelotomy are more invasive, very, very invasive procedures where we basically, it's what I was referring to when I said we would cut out the wires that are transmitting the pain signal instead of killing the cells that are generating the pain signal. So these are procedures where we cut the spinal cord itself in specific areas to stop pain signals from reaching the brain. And usually they're done in patients with cancer pain.
When you're saying myelotomy, what area of the spinal cord would you be targeting?
So it would be a midline myelotomy. So you cut right in the middle of the spinal cord in a specific area, and that basically cuts the signal, the wires that are crossing the midline of the spinal cord to go to the other side, and then go to a specific region in the brain. Or it could also cut the wires that are traveling in the middle of the spinal cord. And usually we do it for midline pain, visceral pain, so rectal pain or somewhere that's the first thing, or maybe bladder pain from cancer or something like that. They're not for for some reason they don't work well for neuropathic pain, but they work well for the visceral pain where you have genuine tissue damage, and that cannot be resolved with surgery or with treatment. So cancer that's invading into the bone, into the rectum, or into the bladder or the pelvis, and you just want to stop that signal. What's interesting about cordotomy specifically is that we usually treat one side at a time, because usually we don't want to risk the possibility that somebody could stop breathing because we do cordotomy right at the brainstem. But what's interesting is that when you take out pain from one side, usually patients, one of the most common side effects is that they start complaining of pain on the other side. And it's unclear whether this is because that pain signal is increased, or it's because they start noticing it more. But that's one of the big things that happen with it.
Something I wanted to actually ask about as well, as we're moving a little bit more cephalad, more towards the head, is what areas in the brain had you mentioned that you could target to help sort of modulate or mitigate pain?
Yeah, so it's the same principles that apply in the spinal cord almost apply in the brain too. So you're either targeting the cells that could generate that pain, or you target the pathway or the connection to stop that pain signal. And if we're incorporating the brainstem as part of the brain, because it's kind of, it's mixed between brain and spinal cord there, but nucleus caudalis DRES is the same procedure of DRES in the spinal cord, but we do it in the brainstem. And the purpose of that is to stop facial pain. And we're going to touch on facial pain later, I understand, but that's one way to do it. The other way to do it would be to do something called a mesencephalotomy, which is a connection. It's a bundle of white matter that connects between the trigeminal nucleus and the brainstem, which carries sensation from the face, and then it goes up to the thalamus, which is a relay nucleus. So that's another area we can destroy, and it's a very rare indication to do that too. The other areas that have been targeted with a less successful, I guess, like success rate would be lower in these areas, would be the thalamus. So there are some areas in the thalamus that have been targeted in the past, VPL, VPM. So VPL for body pain, VPM for facial pain. And most recently, there has been a focused ultrasound study that tried to deal with facial pain with VC, with creating a lesion with a focused ultrasound to try to deal with that pain. And unfortunately, none of them have produced reliably good results. Now, there are areas, pain pathways are complicated. Pain is generally, you have signals that go to the brain. When they go to the brain, these signals split into the area that tells your brain there's pain in your finger. So the somatosensory cortex. But then there are areas that produce the suffering associated with pain, right? And we talked about the car analogy, and more or less these are the areas that get activated when you are sad and upset by that pain that you're having. So that includes the insula, the posterior insula, as well as the anterior cingulate cortex and the prefrontal cortex. Now that's interesting because what we can do is we can target these areas not to stop the pain, but to stop the suffering with it. So we do something called a cingulotomy, which essentially we target both sides of the cingulate cortex, the anterior cingulate cortex, in an effort to not stop the actual pain signal. So patients will continue to experience pain, but they don't care about it anymore.
That's wild. It's pretty.
Yeah, but it is wild, and it's also a little dangerous because it produces a certain level of apathy because they might not care about a lot of things in general, right? So that's an irreversible step. And I mean, I don't know of anyone who's tried to do the posterior insula, to target a posterior insula for that. But I find the posterior insula specifically interesting because of my interest in epilepsy as well. Because one symptom of posterior insular epilepsy is pain. So they would have ictal pain. Whenever they have a seizure, they feel body pain or facial pain.
The whole seizure through, or is it just like you said is it post-ictal or ictal pain? So like during the seizure?
Ictal.
Okay.
So it could be the start of so usually they might generalize, or so seizure starts in a specific area and propagates. It's an electric signal. So it spreads and then you start experiencing different symptoms based on where that signal is traveling. But sometimes if that signal originated in the posterior insula, they might have something like ictal pain. But the target that we use most commonly is the anterior cingulate. There is effort to do DBS of the anterior cingulate and even the orbitofrontal cortex to modulate pain. So it's almost a reversible way to turn off that signal. I know there's some randomized controlled trials right now in California where they are doing it for back pain. So it sounds wild, but you would be targeting the brain to treat someone with back pain because you're trying to turn off the suffering associated with it. So yeah, so those are the major targets that we use for the brain to help with pain.
My understanding of the insula as well is that it's part of consciousness, right? It's what helps us process consciousness. Is that?
So maintaining consciousness is not necessarily part of the insula itself. It's part of the reticular activating system, which is really spread out through the midline structures in the brain. So spread out through the thalamus down to the caudal medulla, basically. And if you think about somebody who has some sort of injury to like a trauma, and then you always talk about uncal herniation and pressure on the brainstem, blown pupil. So when you lose consciousness, it's usually when you have pressure on the midline structures, including the midbrain and going down towards the medulla. The insula itself is, I mean, any injury that's mirrored in the brain can produce difficulty with consciousness. A bifrontal injury can produce something called abulia, where you could be completely unconscious all the way to not caring about anything in life. So the insula, bilateral insular injuries could be risky and could cause some sort of difficulty with arousal and maintaining consciousness, but not when we target like one unilateral, like for pain or epilepsy.
Is this a stereotactic surgery that you're using for the cingulotomy?
Yeah. So essentially, what we do is we target a area of the cingulate which is the dorsal anterior cingulate, and we put a electrode into the brain, into that area, and then we heat it up to about 90 degrees, 80 to 90 degrees Celsius. And that's lasted anywhere from 90 seconds to a couple of minutes. We could create multiple lesions. Another way you can do it is you can use a laser fiber to do that. I have never done that myself during my training, I guess. And so you can use a laser fiber to create the same kind of principal lesion with heat. Yeah, but that's, again, one of the risks that I touched on just now is the risk of abulia whenever you do cingulotomy, because you're producing a bilateral injury, and that, although you stop caring about pain, you might also stop caring about other things.
Right, which is kind of the point of the surgery, to get your quality of life back in many ways. Speaking of quality of life, trigeminal neuralgia can really affect other people's quality of life. I was wondering if you could speak a little bit about the diagnosis, the process itself, what the symptoms are, and when a patient should come see you for it, basically.
So trigeminal neuralgia is a unilateral pain typically. So one-sided facial pain that usually happens in the distribution above the eye or in the cheek or in the jaw. And in its typical or classic trigeminal neuralgia is known as lancinating pain, which means it comes and goes. It's a zap of pain that is so excruciating that you basically almost going to pass out from the severity of it. Almost like when you get the injection in the dentist and you feel that jaw pain, that's the same zap that you get. And that could happen several times. And usually episodic, so they could cluster with like daily pain for several days, several weeks, and it goes away for a bit and then comes back. The other type of it is that you might have consistent pain, so always have some sort of pain in your face, and on top of that, you get those zaps. So that's type 2 trigeminal neuralgia. The mechanism, why does it happen? The brain and the central nervous system is essentially a cluster of wires. And like any wire, you have the wire and you have the insulation around it. The insulation in the brain is different than the insulation in the peripheral nervous system. So you transition from oligodendrocytes to Schwann cells, and they produce the same effect as fatty insulation. That's a different area. And that area is about 4 to 7 millimeters in the first length of that nerve. So the trigeminal nerve, when it comes out of the brainstem, it starts with oligodendrocytes covering it, and then it transitions. That transition zone becomes Schwann cells after a few millimeters. That area is specifically sensitive to compression. And as we get older, our blood vessels could lengthen and coil inside our brain, inside our skull. And they start, sometimes there's a knuckle of that blood vessel pressing on the root entry zone for that nerve. And that sensitive area becomes kind of loses its coverage, and then it starts producing this pain. And usually it produces it whenever that blood vessel is impacting on the nerve. That's a theory, at least. Now, there are people that have trigeminal neuralgia, but they don't have the compression. And then there's vice versa. There are people that have obvious compression, but they don't have trigeminal neuralgia. So usually the classic thinking is, if somebody comes in with trigeminal neuralgia and they have that blood vessel on the MRI, then that is usually the culprit behind it. Usually trigeminal neuralgia is treated with anticonvulsants. So there are usually 2 or 3 medications that are given to patients with trigeminal neuralgia by their family doctor or by the neurologist. And most of the time they do respond well. But kind of goes back to our earlier conversation, a lot of these medications have significant side effects. So sometimes these medications lose their efficacy over time, or the patients may not tolerate them because they might feel sleepy or might not feel themselves or feel foggy while they're taking these carbamazepine or oxcarbazepine medications. So what we do then is they are referred to us, and then we discuss surgical options for them. Now, I am of the opinion that if something can be cured with a slight and not a very invasive surgery or something that's quickly done, and you can avoid taking the medication, that would be great. So I argue that most trigeminal neuralgia should be referred to a neurosurgeon so they can be treated surgically, if not all of them, or at least evaluated. And then ultimately the patient will know that they have the option if they want it, or they can continue medical management if they want it. But they at least deserve to have the conversation with a surgeon.
So where is this compression happening anatomically, typically? Is that like Meckel's cave, or is it more proximal, distal to that?
Proximal. It's usually right at the axilla of the nerve. If you imagine that's the brainstem and that's a nerve coming out of it, it's literally right in the axilla is when the compression happens. Sometimes it's a loop around it.
What percentage of patients would you say present with trigeminal neuralgia and don't have that imaging that shows compression of it?
That's an interesting question. So typically, the numbers in the literature are about 15 to 30%, but in practice, we don't see that often. Most of the time, we see some sort of vessel that is compressing, but then you can argue that about 10-15% of the population have that vessel compressing anyways, and they don't have any trigeminal neuralgia, right? So you might be just looking for that evidence rather than trying to objectively assess it.
How is this different than what's called atypical facial pain?
So that goes back to our original points of when neuropathic pain happens. So neuralgia pain happens in the setting of a normal functioning nerve. So that nerve in the face is carrying normal sensation. You can touch the face, the neurological exam is normal. You touch the face, you wear a hat, they don't have atypical pain from it or allodynia. They don't have any numbness or tingling, none of that. That's because the nerve is functioning well. And atypical facial pain happens when you have some sort of injury to that nerve. And that injury could be because of treatment to trigeminal neuralgia. So somebody could start with trigeminal neuralgia, they get treated surgically, whether it was an MVD or a radiofrequency ablation, gamma knife, which is radiation surgery therapy to the trigeminal nerve. So anything that damages a nerve could result in atypical facial pain. So you start with one diagnosis and end up with another. Could be a tumor, or it could be just dental surgery. It could be a lot of things. So that nerve is just atypical facial pain will produce abnormal neurological examination. That's a hallmark of it. You will also have allodynia. So allodynia is when you have a sensory stimulation that is not supposed to produce pain, that instead produces pain. So you touch someone with a napkin, and then they feel pain. That is abnormal. That is allodynia. That is different than hyperesthesia, which could happen with any nerve injury when you give somebody a pinprick sensation, so a sensation that's supposed to bring pain, but they have an exaggerated response to it, and they have a lot of pain from a small poke. So all of that are hallmark of a neuropathic pain other than trigeminal neuralgia. Rule of thumb, trigeminal neuralgia should produce normal neurological examination.
And then real quickly, what procedures do you offer for patients? And you mentioned them there briefly, including gamma knife. Would you offer for someone with trigeminal neuralgia?
It depends on whether they have a vessel compressing the nerve, and also depends on whether they have a high surgical comorbidity. So they might not be a good candidate to have a very big surgery like an MVD. So in that situation, can you still hear me? Yeah. So in that situation, we could start with something less invasive. So we did a rhizotomy together recently, so we can do that. So we can put a needle under X-ray, and you saw. I mean, it's quite easy to find the hole. It's where you go to the base of the skull, where the nerve is exiting the brainstem, and then you can either burn the nerve with a radiofrequency probe, or you can inflate a balloon and compress the nerve in a way to kind of produce numbness for a certain number of months. The patient that we had, for example, was a patient that had MS and was having significant pain from trigeminal neuralgia, and tried Gamma Knife because they didn't want to take any risky procedure, and it didn't work. Usually Gamma Knife takes several months to work, to take effect. And this way it didn't work. And some patients are suffering so much that they can't eat. They can't eat. So they start losing weight. So in that situation, we can start with something less invasive, do the balloon or the radiofrequency, and see how they respond. The alternative to that as well, other than MVD, we can also do what we talked about earlier, nucleus caudalis DRES. We can do mesencephalotomy. We can go all the way up to cingulotomy in the brain. Now, one of my preferred ways to deal with atypical trigeminal facial pain is to do a neuromodulation trial. So what we can do is we can put the same electrodes that we use in the spinal cord, we can put them in the face to target the branches of the trigeminal nerve. And that could go right here, it could be in the cheek, it could be in the jaw, or we can go in the cheek all the way up to the ganglion. It's the same approach as a rhizotomy. Instead of putting a balloon in, you're putting a wire in. And then that wire will be externalized for a trial and see if they respond with that. And usually we produce pretty reasonable effects. You should know, I mean, that neuromodulation does not completely eliminate pain, or at least we don't advertise it that way. We consider it a success if we reduce the pain by 50%, and that usually is a significant amount for most patients.
This rhizotomy, and this is kind of a side note as well, when you do something like an ablation or a rhizotomy, it's not neuropraxia, it's not exonemesis or neurotomesis per se, it's just damage to the surrounding tissues, it seems. Or would you say it does damage like the endoneurium of the nerve? And because like what I get confused about is that you basically cut or damage the nerve some way, shape, or form. Typically nerves don't grow back, but like you had said, you're getting months of relief. So in some ways these nerves are reconnecting. So what are your thoughts as to like why these nerves reconnect, I guess is my question. Because, for instance, if you do a medial branch block or RFA or medial branches, you'll get maybe around 6 months of relief for facetogenic pain in the back. But the sensation comes back to those facets. Is it because the damage is such a very fractional small area that you're damaging the nerve? Or is it because you're just not completely cutting the nerve, severing the nerve like neurotomesis? Neurotomesis, yeah.
So we have to remember that whenever we are damaging these nerves, we're not necessarily damaging the cell body. So you are right that nerves don't grow back, but axons do grow back, and axons grow back at a millimeter a day. So whenever we are trying to damage these nerves, we're producing a thermal injury. At least the way I look at it is that we're producing a thermal injury, and to a certain level, we are damaging the ganglion to a certain level. So some of that injury might be permanent, but a lot of it is not, and we're just damaging the axons that are going towards the face. And essentially, the reason it comes back later on is because if the cell body is intact, you're not actually producing a neuron mesis, but maybe axon mesis, and then the structure is still there for that nerve to continue. Now, sometimes whenever we do if we do an MVD and it produces a good effect, and then we're coming back again to do the MVD again. So sometimes we cut the nerve. So we do a neurolysis in the brainstem. And at that point, we are cutting the nerve, and we know there's definitely a discontinuity. There's no going back here. There's nothing growing back. And at that point, you might end up with something like deafferentation pain. At that point, you have committed to either being pain-free, or some patients might produce deafferentation pain, which means that if this patient comes back later on, you won't be able to do rhizotomy, you won't be able to do peripheral nerve stimulation on them because there's nothing that's connected. Now, this pain is originating in the brainstem or even in the brain. You need to start thinking more invasive and more proximal.
Appreciate you explaining that. And just lastly here, where is the field of functional neurosurgery heading? Do you see any things on the horizon, new procedures, new thoughts to the field? Just curious.
So it's funny, the field of neurosurgery in general is very young. It's about maybe 120, 130 years old in modern neurosurgery. But what we have been doing recently is that we're going back to some old techniques and procedures that were forgotten before because we have new equipment to use. So we're using focused ultrasound to produce thalamotomies for essential tremor and try it for pain, try it for Parkinson's disease, when for the last 20 or 30 years, we have been using neuromodulation, which is basically achieving the same effect in a reversible way. But now we can do that in a safe way and not have an implanted device and achieve a similar effect. So we're seeing this resurgence of older techniques, including DRES. DRES is a technique that was described in the late 60s, and now we're seeing more and more of it because it was underutilized for so long and not advertised as much. Also, what we're seeing more of is resurgence of gene therapy and cell therapy. So we're trying to, specifically for degenerative diseases, so Parkinson's disease, maybe ALS to a certain extent. Sorry about that. So those are diseases that are essentially starting in the central nervous system, and they have cell populations that are dying, and we try to replace them and kind of change the genomic nature of these cells. So this is exciting and new ways to do it. Also, there's neuromodulation in the brain, the implanted chips that Neuralinks that has been advertising. But these are technologies that we've been doing for a long, long time. But we're repurposing them now into different ways and trying to make them more compact, more accessible. So this is all new and exciting in general.
Dr. Alan Chalil, thank you so much for your time. I really appreciate it. That was great. Such a wealth of knowledge and skills. I've seen it in the OR myself. Thank you.
Thank you. Thank you so much for having me. That was really fun. And I really look forward to listening to the remainder of the podcast and all the episodes. Can't wait to see what comes out of it. I really appreciate you inviting me.